Today our patient is Miss Terry Wilcox. She's referred to us for medical nutrition therapy for cirrhosis. Her food nutrition related history indicates she's had a poor appetite for 2 weeks, her daily intake being orange juice for breakfast, soup and crackers for lunch with Diet Coke, and carry out Chinese or Italian food for dinner. She has not eaten anything in the past 2 days, and she's had some previous nutritional therapy indicating to her to eat small, frequent meals. The patient is currently 26 years old, female. Her height is 5'9". Her weight is 125 pounds, and 6 months ago she was 135 pounds. She's had a 10-pound weight loss in the past 6 months, and her BMI is 18.45, which is considered underweight. Looking at the patient's labs, she currently has some abnormal lab values. Looking at everything that's under other, these are all indicators of her liver dysfunction. The high bilirubin, ALT, AST, ALK, phos, CPK, and triglycerides are all controlled through the liver, and having those in higher concentrations indicates that the liver is not functioning properly. It's also indicated that the patient has high mean corpuscular volume and low hemoglobin, which are indicators of macrocytic anemia. The macrocytic anemia generally results from a folate or B12 deficiency, which in this case would be due to her liver dysfunction, as the liver produces the proteins that carry the vitamins. The body's not able to utilize them due to the dysfunction, resulting in deficiency. Looking at the patient's current medical diagnoses, she has probable cirrhosis secondary to hepatitis. Cirrhosis results from liver cell death resulting in the growth of scar tissue within the liver, which is not functional as liver tissue. This results generally from anything that causes reduced blood flow to the liver, toxicity resulting in cell death, which generally it's going to be alcohol toxicity or toxicity from excessive vitamin intake. Things like vitamin A is very common to be taken as a supplement and to reach toxic levels, causing liver damage. And in this patient's case, she has cirrhosis secondary to hepatitis, which is a virus that causes inflammation of the liver and cell damage, resulting in that scarring within the liver as well. To diagnosis, she had a CT scan of her liver. She also had an endoscopy, which was most likely used to diagnose her with the enlarged esophageal veins. These are basically veins within the esophagus that get distended and enlarged, resulting from portal hypertension. She has some mild abdominal distension, which is generally the result of fluid retention, and she also has some splenomegaly, which is again a result of the portal hypertension, causing enlargement of the spleen. Currently, she's on a couple medications. She's on Yaz, which is birth control, Allegra, which is an antihistamine for her allergies, spironolactone, which is a diuretic for the abdominal distension and the fluid retention, just getting rid of that excess fluid, and it's also an antihypertensive for that portal hypertension she's experiencing, as well as the propranolol, which is an anti-anxiety and antihypertensive for the same purpose, the portal hypertension treatment. She takes a multivitamin, vitamin E, and vitamin D at home, which is concerning given her liver function. It's not able to process the vitamin D and E into a storable form, so there's potentially a buildup of those vitamins in her blood that aren't being used. And given the multivitamin most likely has some vitamin E and D in it, she's putting herself at greater risk for reaching those toxic levels. She also was taking milk thistle, chicory, and ginger supplements. These all have some sort of impact on her liver function. The milk thistle according to the National Council of Complementary and Alternative Medicine, is used to promote liver cell growth, and it also has an antioxidant effect. One thing to be careful with the milk thistle is it can have a hypoglycemic effect if taken with other medications that cause hypoglycemia. The chicory is also has an effect on the liver. It's supposed to have some anti-hepatotoxic effects. These aren't very well supported, so it's not necessarily something that we encourage her to continue taking, as there's not a lot of evidence behind taking the chicory root. There is a little bit more research behind the milk thistle, but given she's in this acute state, we wouldn't want her to be taking any supplements that are going to have potential interactions with her medications. And she's also taking a ginger supplement, most likely to relieve nausea. The ginger supplement really doesn't have any bad side effects, but given that supplements may or may not contain exactly what they say, it's again one of those things that we'd want to maybe make the patient aware of while she's being treated acutely. In the patient's medical history, we note that she's had the hepatitis C for about 3 years. And in her family history, there's quite a few hepatobiliary diseases on both her mother and father's side. There's cirrhosis on her father's side, the cholecystitis on her mother's side, and she does have a history of her father having the peptic ulcer disease. And just given this history of all these genetic factors, we want to keep an eye on that and keep her cirrhosis in good control so that we don't potentially trigger any of these other genetic factors. The patient's estimated nutrition needs are based on Mifflin St. Jean with an activity factor of 1.4, given she's in the hospital currently. We don't want to give her too high of a caloric intake at this point, just because she's going to be less active. So 1.4 is the general recommendation there. So we get 2,300 calories per day. Her protein is based on 1.2 grams per kilogram, which is common for cirrhosis, and that is recommended by Nutrition and Diagnosis Related Care and Escott Stump. Her needs calculate out to be 67 grams per day, and her fluid needs are 1.7 liters per day. And just to be precise with her fluid needs, we want to make sure we're not overdoing it, because she does have a tendency for fluid retention and the potential for ascites given her liver dysfunction. Her current diet order is 4 grams sodium, soft foods, high calorie, and high protein. She feeds independently. She doesn't have any chewing or swallowing problems that are noted. She does have the large esophageal veins, but nothing functionally is wrong with her chewing or swallowing. And her intake is noted to have been minimal for at least the past 2 weeks, and especially in the past 2 days. She has had nothing. So looking at the nutrition diagnosis, she has increased calorie and protein needs related to her compromised liver function, as evidenced by her 10-pound unintended weight loss. She's considered underweight at this point, and she has unexplained bruising. And we also see that she has an excessive intake of vitamin E and D related to liver cirrhosis, as evidenced by the patient's supplementation of vitamin E and D, in addition to the multivitamin and progressive liver failure and questionable jaundice at this point. So those are obviously adding some sort of toxicity to her intake. Her recommended nutrition prescription, I increased her sodium restriction to being only 2 grams of sodium, soft foods, high calorie, high protein, 2 liters of fluid restricted, and 5 to 6 small meals a day. So we're sticking with the small, frequent meals, but we're just defining it a little bit further for this patient. I decided to decrease the sodium, given that she is being treated with a diuretic. We don't want to increase the fluid retention by having her have a lot of sodium all at once. The soft foods, again, are for her esophageal veins being enlarged. It's more comfortable to have the soft foods, and she does have the increased needs for protein and calories at this point. Her needs are going to be met through meals and snacks. We are going to educate the patient on her sodium restriction and high sodium foods, high calorie and high protein foods, as well as why she should discontinue taking vitamin E and D due to the toxicity to the liver, and make her aware of the interaction with propranolol and licorice. And it's also recommended with a propranolol that it be taken with a low sodium diet to improve the effects. So, looking at counseling, although it's not indicated that she does consume any alcohol at this point, we want to make sure that she doesn't start drinking alcohol, as that can cause further destruction of the functioning liver cells and further cirrhosis. We want her to gain weight steadily, but we also want her to know the signs of fluid retention. Given, fluid retention can cause the weight gain, we want to make sure she knows that she's gaining actual body mass and not just holding on to fluid. So those are things that we would counsel her about. So for her goals, we want weight maintenance and steady weight gain, her PO intake to meet her increased needs, and to reduce the potential for vitamin toxicity. So given those goals, we would measure that by monitoring the patient's weight. We want it to stay within plus or minus 3% each month if we see her regularly after she's discharged. And we want to see a steady weight gain of about a pound a week. And that will just help reduce the potential for it to be fluid overload being overlooked. As far as PO intake, we want the PO intake to consistently meet 100% of her needs each meal as indicated in meal rounds. Because of her recent weight loss and the fact that she's now considered underweight, we really don't want to have any sort of flexibility in her intake, potentially not meeting her needs. And that's why if her intake is less than 75%, we're looking at supplementing her right away, just to ensure that she's going to meet her needs. And then to reduce the potential for vitamin toxicity, just encouraging the patient to discontinue her vitamin E and D supplementation, as that could potentially be causing further liver damage. And these were my few assumptions and resources for this case. Thank you.